The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. As always, the months that I really enjoy the most are the ones where something has really caught my eye and I want to talk more with someone. And we're very fortunate this month to have Camille Fung with us. Camille, my introduction to you talking about this is that, as you know, with everyone else in the world, I had to do continuing education to renew my DEA license. And I wanted to find something that was pediatric related. And then I found that there was this really great course that was done locally. And not only did you do a superb talk on this topic, but you were the course master for the whole thing, right?
I did. Yeah, included adult and pediatric medicine.
Yeah, I just thought it was terrific. So I've been looking forward to having this conversation. Our guest this month is Camille Fung, who is an associate professor in the Division of Neonatology in the Department of Pediatrics at the University of Utah. And not only that, you have a lot of research interests. And if I read your bio correctly, you are the recent recipient of the Clark Endowed Chair for Pediatric Research.
Yeah, I received that last year.
Wonderful. Good for you. I see, looking at your bio, that you went to college at Santa Clara. I should tell you that years ago when I was on the intern selection committee at the University of Utah, Rich Multini was in charge. I thought Rich was a wonderful guy. But anyone who trained at a Jesuit college, he said they get 2 extra points because, you know, they're smart. So you started at Santa Clara and then went all the way to the East Coast for your medical school and your pediatric training. Is that right?
Yes.
Then back to the West Coast for both your fellowship and research fellowship as well, right?
Correct.
So where are you from originally?
Hong Kong. Can you believe that?
I can believe that, I guess. And then you came and educated yourself from sea to shining sea.
Yeah, Hong Kong. And then I actually received some of my education in England from 13 to 18 years of
really?
age. I was in England for boarding school.
Oh,
And
my
then
goodness.
my family immigrated from Hong Kong to the United States, which is why I joined them here for my college education.
Oh, interesting. So well-educated and well-traveled.
Yeah, I suppose.
That's a wonderful thing. Well, we should dive in. Before we proceed, do you have any disclosures that you need to make?
I do not have any disclosures.
Then let's jump right in. So we want to talk this month about, I want to make sure that I get this right, neonatal opioid withdrawal syndrome. And right from the first, that caught my eye because often we've referred to this as neonatal abstinence syndrome, and this just makes a lot more sense to me. Abstinence is an interesting term to use for newborns anyway, I think, right?
Yeah, so the CDC changed the terminology, I think back in the early 20, well, maybe late 20 teens, to try to be more encompassing to include the cohort of children who are really going to be needing more pharmacological treatment. And I think opioid exposure is one where they really have trouble and will stay in the hospital for longer. So that's where the terminology changes. Abstinence it's just kind of, I don't know. I think it's just in line with the opioid crisis. People change the terminology to try to be more encompassing about the opioid exposed neonates are the ones who are really going to struggle.
And you'd have to be really not paying attention if you didn't recognize that there's been an opioid crisis a couple of decades. It's interesting. The author, Sam Quinones, who's written a couple of really good books about the opioid crisis, wrote a book about tubas last year just to clear his mind from so much immersion in the opioid crisis. Tell us, from your point of view, what is the scope of the problem?
Yeah, so I would say at the beginning of the opioid crisis, it really was attributed to prescribed opioids. So this is probably in the early 20 teens. Pain was something that a lot of hospitals paid a lot of attention to. And I think it spurred on with JCO trying to make sure everyone's pain was managed. And so pain, I think all I remember is people always like, are you documenting pain? Are you documenting pain?
Yeah.
And so that escalated to, I think, both inpatient and outpatient, there was a lot of focus on pain management. And so a lot of pain prescriptions were being dispensed in order to address pain. From what I heard, I don't know this for a fact, but a lot of drug companies also were giving incentives to hospitals and physicians to try to encourage more pain prescription to be dispensed. So I think that really escalated. And there was not a lot of regulation as to how much pain meds you could prescribe. And so I think that adds to the problem. And so it really escalated in the early 20 teens with prescription opioids. And so with people recognizing opioid overdose becoming a big issue and people needing a lot of opioid treatment, the amount of prescription opioids started to go down because of just education to the healthcare community. But now we're faced with a completely different opioid exposure, which is the illicitly manufactured fentanyl that is permeating through all the streets across the United States. And so now we have a huge fentanyl problem. And oftentimes, fentanyl on the street is not pure fentanyl. It's usually laced with a lot of other addictive substances to try to get a better high, so to speak. It's becoming very scary because people don't actually know exactly what they're buying on the streets. It's not pure fentanyl. Oftentimes, it has maybe some benzos, maybe some ketamine, and more people are dying because they don't know what they're getting.
You know,
But
Camille, I'm so incredibly naive. As I was listening to your talk a couple of months ago, it occurred to me that when you buy fentanyl on the street, it's not like, it's this many milligrams. You're just buying something, and that's staggering to me, the thoughts of something that has so much potential that, a dose could kill you.
yeah, exactly. Nobody knows exactly how much they're buying. And again, the quality and the quantity is unknown. I would say for the first time, though, statistics have shown maybe 2023 to 2024, we're starting to have a little bit of a bend in terms of how much fentanyl overdoses is being noticed. And so, hopefully the public is getting educated and we're realizing that street drugs is creating havoc, I think, for the American people. And hopefully we're starting to curb that more and more now.
So what's the impact been for newborns? Can you give us some notion of how many more newborns are affected?
Yeah, the newborns is interesting because I think the newborns lag behind a little bit from what the adults are doing. So the mother who is pregnant with a newborn, who becomes addicted or misuse opioids, they're in a really difficult position. Oftentimes, obstetricians aren't fully trained to deal with opioid use disorder. It's getting better, but a lot of OBs are still not as up to speed. And then the psychiatrist who may be dealing with opioid use disorder isn't able to manage the pregnancy and how to titrate doses of medications relating to opioid disorder. So I do feel like the moms are kind of in a no man's land because neither specialties is, fully able to handle their opioid disorder, which is why I think it's really important that at the University of Utah, we have the Super Rad Clinic run by Dr. Marcella Smith, who is a maternal fetal medicine, but also very well versed in how to manage pregnant women with substance use disorder, not just opioids alone. She manages other types of substances. So I think we need more and more of those clinics to help these mothers so that hopefully they get placed on, medication assisted therapy. Newborns hopefully are not withdrawing as much when they are born. So I think it's not going away. Until the opioid crisis goes away, I don't think the newborn problem of neonatal opioid withdrawal is going to go away.
Let's talk a little bit about the physiology. Do the opioids cross the placenta at serum level, or how much is a fetus exposed?
Yeah, I wish I could tell you exactly it's a one-to-one relationship, and it really isn't. There are many levels of drug metabolism that occurs. So when a mother takes in a substance, depending on her own dose and how long she's been on it, she has her own clearance. And then at the placenta level, oh, and I was going to mention too, a lot of mothers, unfortunately, now have polysubstance use. she's trying to clear multiple substances at once. And then at the placenta level, the placenta itself has its own metabolism. So how much gets cleared before it's transferred to the baby is certainly unknown. And then the fetus himself or herself has their own metabolism. And that's oftentimes also governed by the dad, because the baby is a combination of the mom and the dad. So the dad may have a different metabolism from the mother. So I think it's always really hard to know exactly how much is transferred from the mother to the fetus. And even if it's the same dose, for example, for the mom and the same class of medication, the babies can actually withdraw in a very different manner.
Fascinating. And also, I'm reminded as you're talking that we don't see as much use of chronic, short-acting prescription opioids, but we do then deal with self-dosed, short-acting opioids, fentanyl and heroin and whatever else is available. And then we also, you alluded to this briefly, then we also have the very long-acting opioids that are typically used for people who are in recovery.
Yeah, I think oftentimes the pattern that I have seen and have heard and read is that, a pregnant mother gets a prescription opioid from the past and becomes quickly addicted or tolerant. So when they run out of their prescription, sometimes they don't have anywhere to go, but
Yeah.
maybe either borrow from somebody else or they go on the street to try to get some heroin to temporize the withdrawal. But, again, we talked about street drug is not pure of anything. And so unless they get captured by a subspecialist who knows how to manage her opioid use disorder while pregnant, then they can get prescribed. Either nowadays is buprenorphine has really come on board because of the data waiver that passed at the end of December of 2022, where you don't need to get a buprenorphine license, so to speak, to give buprenorphine. Used to be a very onerous process to be able to prescribe buprenorphine. Or mothers will go to methadone clinic, an outpatient methadone clinic, which is effective in a way, but I have also heard from mothers who have gone to methadone clinics is that oftentimes it is very hard to get to these methadone clinics and first thing in the morning, or it's very early in the morning. They don't have transportation. They don't have someone to watch their other children. So it is hard to get to a methadone clinic. So buprenorphine really has become the more fashionable maintenance assisted therapy.
And when you say fashionable, in many ways more manageable for providers and for patients.
Yeah, and studies are starting to publishing to say that maybe even mothers on buprenorphine for their assisted therapy, the babies may not withdraw as much. So that could be dual benefit for both just, managing the mother plus maybe withdrawal for the baby as well.
Let's talk about the signs of withdrawal. In many ways, these are the same sorts of things that people generally, that adults withdrawing from opioids would have. So let's talk first about the neurologic excitability that you may see.
hmm Yeah, I think of the neurological excitability are things like, hyperactive morale, hyperactive primitive reflexes in general, hypertonia, the irritability, and the high pitched cry. I think once you've heard one, you will recognize it. Tremors is another neurological sign. And then, something people don't always think about is the sleep wake disturbances, just the inability to stay asleep while you are asleep. That's actually part of the withdrawal for the neurological excitability. And also, people most feared complication, I think, is seizures. But I don't think, in the last, 20 years and maybe even more for you, Paul, I've never seen a baby seize from withdrawal. But I think that's something that is always talked about, that we're worried about withdrawal and baby seizing. So those are the big neurological signs. And really, I think for people just to try to remember, and this is what I tell my trainees, is that when you have drug withdrawal, essentially you have a jacked up nervous system. That's the best way I can explain it. And so a lot of the hyperexcitability is because the brain is just so overstimulated.
And, as two people who take care of newborns routinely, all of these things complicate the transition process after birth. All of these things make the fundamentals more difficult.
Yeah, I mean, babies, they only supposed to have to eat, sleep, and poop and pee a little. But when you're so hyper excitable, it makes a lot of these physiological states very hard to maintain.
Well, let's talk about the GI stuff. What GI stuff would we expect to see?
Yeah, so the GI manifestations, actually feeding difficulty is one that is underrecognized. I think many of us are used to babies eating a lot, right? They just want to suck, 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 suck. So they eat, 150, 200, 250 milliliters per kilo per day. That's what you see, more typical. But the inability to coordinate suck, swallow, feeding is actually just as important as a GI sign. So that's one. And then vomiting and diarrhea are big ones. And there are a lot of opioid receptors actually that line the GI tract. And so when these opioid receptors are out on the surface because of the in utero exposure, and when there's no ligand to bind, the result is you get vomiting and diarrhea. So those are the big ones. And I always tell people that when you have vomiting and diarrhea, no matter what other signs are present or not, you really got to treat the baby if you can with an opioid, because otherwise you cannot manage the diarrhea part of the GI symptoms.
And we'll talk about this a bit next week. In some ways, one of the difficulties here is that these things exist on a continuum to some extent. And so, a lot of babies are going to be spitty in the first day of life or so, but we're talking about more than that.
Yeah, the vomiting is constant. It's not just a little bit of a wet burp, right? And then diarrhea, we used to think of it as you have to have no bits in your diaper. Really, these are just runny, watery stools, and it's also the frequency, right? It's not just they have a couple runny stools. They are just kind of squirting the whole way.
And again, we'll talk about this a bit more next week, but what stage are we seeing this? So how quickly does a baby transition from meconium to diarrhea?
Yeah, I mean, it's pretty quick. I think, once they pass their initial meconium, and oftentimes they're, even with short acting exposure of opioid, they're usually not presenting with symptoms on the first day, but maybe after the first day, they're starting to have some withdrawal symptoms. So they'll just keep passing meconium the first 1 to 2 days, and then they start to transition to having more transitional stools. And then it's just voluminous. It's just coming out, and the nurses will tell you their butts are raw. They're constantly having to change them because there's just no substance to the diaper.
How about the autonomic signs?
Yeah, the autonomic signs are more like fever, sweating, mottling, yawning is another one, and then kind of the nasal stuffiness and congestion that we sometimes hear neonates will have.
And there again, that's a matter of degree, isn't it? Because one of the things that I address most commonly in the first couple of days of life is, my baby's sneezing a little bit, my baby is a little stuffy, but this goes beyond that.
Yeah, and I think, it's probably not just isolated to those. They would probably have other neurological or GI symptoms as well. But I think in concert, all of these big neurological, GI, and autonomic signs put these babies at really high risk for failure to thrive. If you can imagine, they can't eat, they can't sleep. They're hyperexcited, they're tremulous. I mean, I just don't know how you're supposed to be a regular baby when all of these things are happening.
Yeah. And we should probably mention again, you've already discussed this, but this is really what it all hinges on, is trying to anticipate when it's going to happen and to what degree it's going to happen depends on the agent, depends on the metabolism. And the main thing, we just need to have our eyes open.
Yeah. And I think just be open to talking about this problem with the family. I think that is really important, is that, I think a lot of mothers know what it's like to withdraw and how rotten it is. So I think if you go in with the notion that your baby has been exposed to whatever substance, and it is our job as pediatricians to anticipate withdrawal. And I think you just tell the mom, we may also have withdrawal, and I'm sure you've had withdrawal symptoms in the past. And just say, our goal is to try to help that baby through it. just similarly to when you have withdrawal symptoms. And just be really open and compassionate would be the key, I think, in trying to kind of open up that conversation, because a lot of these mothers feel very judged to start with, and there's a lot of stigma associated with it. But I think if you just be kind and open and just say, I'm just trying to make sure your baby is safe, oftentimes that goes a long way. I think just being compassionate.
Yeah, with almost everything we do, right?
Yeah, particularly this topic, I do feel like
Yeah.
this one's a hard one because they don't want to tell you anything, right? They tend to be kind of closed off.
Yeah, and I don't think anyone would end up, buying fentanyl on the street unless they have experienced a withdrawal before. That's not something that you wake up in the morning and say, here's how I'm going to plan my day. I'm going to do the laundry, I'm going to do some shopping, and I'm going to go buy some fentanyl. You do it because if you don't, you feel sick. And
Correct.
I think most people are capable enough of feeling guilty and judging themselves that I think they deserve whatever measure of compassion we can give. And I think that when we see this as an illness rather than as a, bad lifestyle choice, I think it's easier to summon our better angels.
Yeah, completely. I mean, I always tell my trainees, a lot of these mothers who get addicted to substances, they've had a life probably that's, it's hard or just really unanticipated. This is not a life typically what people choose to go down. But, something happens and then you're down this path of where things get out of control and you're just trying to survive. Like all of us are trying to get through the day every day. So
Yeah.
we just have to take that spin into our practice.
And we'll talk about this more in future episodes, but most of these babies are going to go home with these parents, and our job is to equip them for success, that we become a dependable, compassionate safety net, trying to give both the parents and the child the best life possible.
Absolutely. And, I deal with it all mostly in the inpatient setting. You guys do it in the outpatient setting. And
Yeah.
yeah, just because a baby gets discharged from the hospital with opioid withdrawal, it's not the end. There could still be periods of irritability at home. And even, we'll talk about this later. They are at higher risk for neurodevelopmental delays. And so there's still a lot that can come up even after the initial hospitalization.
Yeah, no question. Well, Camille, this has been just as interesting as I hoped it would be. Thanks so much for coming on with us this week. I'm sure that our listeners will have questions, and I'm hoping that you'll be willing to deal with those in a couple of weeks. So for those of you who have questions, please send your questions to questions@vcurb.com, and we'll talk about those. Camille Fung, thanks so much for your time today, and we'll talk again next week.
Thank you for having me.
Thanks for joining us. We look forward to getting together again next time. The virtual curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Thanks to Phil Wirkus, who composed the theme music. See you next time.